You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, this is William Wiley. I'm here again for our second part talking about enhancements of intraocular lenses and how do you enhance those challenging cases after cataract or premium intraocular lens surgery. I'm joined again by my colleagues Blake Williamson, Priya Mathews, and Arjan Hura.
Again, in the past, we just had basic cataract surgery and pretty much assumed that the patient was going to be wearing glasses. And so we didn't worry too much about touching them up. But now the day of premium IOLs, the expectations are so high. And for those lenses to perform well, you want to hit that target. We've got trifocals, extended at the focus. We're doing mini monovision, all these things. And for them to have the best outcome, you really need to hit that refractive target. So, I'd love to go over just a few scenarios with you all regarding touching up or enhancing a lens-based procedure. And so y'all pitch out just kind of a softball here. Let's say you did a toric IOL, you put it in and you're planning on, let's say it's sitting at 180 degrees and they come back and it's off 20 degrees. Let's say it was sitting, in one of your referring doctor's office, and now you're 6 weeks out and it's sitting at 20 degrees. And more or less, the astigmatism is not corrected. They've got a diopter or two of astigmatism. The toric lens is really not functioning. What's your go-to method for solving that toric lens that is off axis?
I think you need to rotate it as soon as you can. The earlier the better, especially with some of these lenses like the Technis, the new Technis 2 is super sticky, almost too much so. That's why it doesn't rotate near as much. All the fibronectin on the Alcom platforms also gets really sticky. So you want to try to rotate that as soon as you can. Certainly want to do a refraction, and they have all the online calculators that you can plug in to kind of see where you need to go. But if you've got a solid 20-degree rotation, I would try to go in and rotate as soon as you can to make it easy for you.
Totally agree. Any other thoughts on a pretty straightforward toric misalignment?
Yeah, agreed. And then, I give the patient, I've done LASIK on these patients too, even if the toric rotated. Let's say it was a really small pupil, or let's say I think that they may even need a touch up after that. I just go ahead and, do the LASIK and take care of both. Here, the spherical equivalent is 0, right? A plus
Yes.
1 minus 2. So that means you're pretty much hit it on target. So you have more confidence that a toric rotation should work well.
That's a good point. You want to kind of get a sense of what the refraction is going to be after a rotation. Worst case scenario is you rotate it and get it back to the intended axis, but they still have a refractive error. They're like, Doc, you put me back through the ringer here and I'm still not happy. So you want to be confident that adjustment is going to get you to where you need to be. Arjan, now you have some thoughts on this?
Yeah, I totally agree with what's been said so far. My default here would be to just definitely rotate that IOL back to position. But like Priya said, sometimes doing LASIK is the right option. And this is a patient where the spherical equivalent for the refraction is essentially plano. If they weren't a good LASIK candidate, you could do PRK for them and still have a pretty reliable postoperative outcome. For some patients, as surgeons, to us, taking a patient to the operating room isn't a big deal. But for a lot of patients, going through cataract surgery can be anxiety-provoking, lots of stress, and the thought of having to go back to the OR again and go through all of that, even for something as simple as just rotating a toric IOL, sometimes psychologically that can be a lot to take in. So these patients are sometimes much more amenable to just doing LASIK in the laser suite. The only other thing I would bring up is the timing of doing this. Like Blake said, you want to rotate the IOL if you're going to rotate it as soon as possible to make that job easy, but if you're going to do laser vision correction, if you're going to do LASIK or PRK, most surgeons are going to wait at least several months to make sure that the refractive error is stable. So now, if it's a patient who maybe, depending on their personality, might be itching to get it corrected, that's when maybe rotating the IOL would be the more preferred option.
Thanks, Arjan. Great thoughts there. So let's go over another scenario where you've nailed the astigmatism. The patient comes back, 0 still, but you've put a trifocal in, let's say, and now they're hyperopic, say +1, +150, and the patient says, Doc, my distance is blurry, my near is not quite where I want it to be. What's the group's favorite approach, or more or less just a hyperopic spherical correction? Let's say you're 6 months out of surgery and you want to get that patient to the right spot. So if they're +1, +150, what are your thoughts there?
I would explant it as soon as I could. So the
Yeah,
sooner the better. A plus 150, even if they're two months out. If they're a solid plus 150 at month at 4 weeks out, and they're a solid plus 150 at 8 weeks out. That's even a case where I'm not going to make them wait 3-4 months, because that's the thing is, like, you always hear, oh, you got to wait 3 and 4 months for sure because you never know. But that patient
sure.
is like so unhappy every single day of those months, and that third month, those last 30 days, talking about, all to their friends, oh my gosh, I paid all this money and I can't see anything. That's someone that I'm pretty, it's a pretty easy answer to go ahead and, explant them as soon as you can, and put a different prescription implant in, and they'll be very happy. I just don't like doing a hyperopic ablation on top of a trifocal lens. It's better just to swap it out, I think.
Yeah, I agree. I think that's a tough treatment to do. Hyperopic on the cornea, particularly hyperopic PRK, I think is a tough go. I feel like those regress a lot. It's hard to predict. Hyperopic LASIK even has some ability to regress over time, and so I agree. How about you ever consider piggyback IOL on this scenario?
In this setting, I would exchange it. I feel like that's the most straight.
Expansion.
You're going in the eye anyways, you know. But I
Yeah.
am curious to ask you both, or all three of you, um, is there like a maximum amount of time that that you would consider exchanging it? So if they're over a certain number of years, would you say, sorry, you can't exchange it for whatever reason they couldn't come back in between? Because this patient was 1 year out. Is there a max time for you?
For me at least, like if they if they haven't had a YAG, then really within that whole first year, I feel pretty confident that I can get it out. Let's say it's like year two, they're 2.5 years in, and they haven't had a YAG yet. Um, you know, you may be okay, but that may be a situation where I say, hey, listen, this is a more difficult case. Here's what could go wrong. Worst case scenario, what I may do is just amputate the haptics, and put in a monofocal implant into the sulcus. Now, that's not going to give you that beautiful near vision like you have, but hopefully you're having some pretty good near vision in the other eye, and you'll still have some functionality there. So I've had that happen a few times where I just, I can't get the thing out, and I'm about to rip the bag, and I say, you know what, I just amputate the haptics, slide in a sulcus lens, and they do very well with that. But that's, that's a conversation you'd want to have. But as far as like a clear cutoff, I start to get more concerned, or less confident. I would say that when someone's had that implant in there for more than like 3 years, that can get kind of a sticky situation. They can end up worse than what they started with, and if you're the one that, if you didn't do the primary surgery but you're doing this one, they're your baby now. The second you touch
That's
them,
right.
so it's like all those considerations come into play for me. Bill, what do you think?
Totally agree, and I think those are tough cases, and a lot of times you don't know what you're going to get until you get in there. And so I've done it as far out as 3, maybe 4 years, um, and but sometimes you just can't get the lens out. So sometimes I have had to amputate the haptics like we discussed. But a lot of times, if it's just a sphere correction I'm going for, I'll have our consent discuss that we'll do either lens exchange or secondary IOL or piggyback IOL. So I tell them, you know what, I'm going to try to get it out. I think there's something psychological that goes along that the patients perceive like this lens is not good. I want a different lens. So if you can exchange it, I think there's some psychological benefits that goes into that by removing, quote, the bad lens. But I tell them, you know what, sometimes that lens is challenging to remove and we can just put a secondary lens on top of it. A lot of times these patients have had contact lens trials to show what it might be like. I'm like, it's just like the contact we place on top of your eye. This is now just going to go inside the eye. We'll place a secondary lens, and they've had great success there. Arjan, I know we had you look at in Cleveland some results of secondary IOLs or piggyback IOLs. Any thoughts as far as the type of material and some of the dogma that's out there after your analysis of a series of cases?
Yeah, this is a little bit of a branch off of what we were discussing, but historically, I feel that surgeons have always feared piggyback lenses because of the risk of interlenticular opacification. But truthfully, that has only really ever been shown with two acrylic lenses placed in the capsular bag. And so for the longest time, surgeons have felt, okay, as long as one of the lenses is acrylic and one is silicon, as long as one's in the bag, one's in the sulcus, then things are safe. But what we demonstrated in Cleveland, actually looked at our past 10 years worth of piggyback lens data, we always had one acrylic lens in the bag and then a second acrylic lens, usually a Sensor AR40, as the piggyback lens in the sulcus. And when I brought these patients back, dilated them, took slit lamp photos, what we found was that the incidence of interlenticular opacification was 0. And so we feel that as long as one lens is in the bag and one lens is in the sulcus, both of those IOLs can still be acrylic. And I really like the AR40 lens. It's a great 3-piece lens for the sulcus. And sometimes, especially if you're trying to mitigate this residual refractive error several years out, where it may be a little bit difficult to get the lens out of the bag, slipping in an IOL into the sulcus, especially if it's not a high-powered or thick lens, it's a very simple and elegant way of potentially just correcting most of the refractive error on the spot. And sometimes, if they had a lot of residual refractive error, maybe even just cutting down on it so that it's only 20 to 25% of that is good enough. And sometimes good enough is better than trying to be a hero, and then you can get into a mess where the bag is out and you're suturing an IOL later. Because like Blake alluded to, I think informed consent for these patients is really, really important. You want to take a scenario that's maybe suboptimal, you want to try to improve it. Maybe you can't get it perfect, but maybe improving it is still enough for that patient. You just don't want to put them down a path where now they're like, I wish I'd never gone through with this in the first place.
Yeah, agree. Well said. I'm going to pitch one other scenario, another intraocular procedure, implantable contact lens, ICL. I think we've seen it's a great surgery in general. These patients are some of our happiest patients. A lot of them are high myopes that were not good candidates for other refractive surgery. So you put an implantable contact lens in, they've got great results. In particular, the new Evo, I think, is taking a step forward, eliminated the need for YAG-PI, some safety aspects there. Now it's on a toric platform. And so in general, we can treat almost any refraction, and even some of the low refractions do amazing with the Evo. Blake, you've had some success with low myopes and with the new Evo platform. But let's say you have one of these Evo lenses and you're correcting astigmatism and the lens rotates, let's say 90 degrees. Doesn't happen often, but it can. Any thoughts on addressing an Evo ICL that's rotated sometime in the postoperative period? How do you address that, Blake?
Yeah, I mean, typically I try to rotate it back. I think that
Yes.
there's different ways that you can skin this cat. It's particularly if it's a bigger eye. Let's say it's like one of the larger ICLs. I have had friends that this has happened to, and they rotate it, and it rotates again, and they rotate it a second time, and it rotated again, and then finally they just explanted it and just did a spherical and did LASIK for the astigmatism correction. And so some people, if it's a bigger eye, will just go straight to that and put in the spherical. I have yet to have to rotate an Evo toric ICL. I'm sure I
Yes.
will at some point. But I think that the way that we think about it is you should always do the easiest thing first, and the easiest thing to me is just rotating that. Remember that it's pretty common because of where these things sit. We know now from Roger's work. He's done all the UBMs recently on these that most of them are in the ciliary body. They're not in the sulcus. And they'll have some foot plates of the sulcus, some in the ciliary body. And so as a result of that, that can lend itself to the rotation. Anything in this first 24 hours or so that can happen to. So what I try to do is I would try to rotate it back and hope that it all winds up in the sulcus and not half in the ciliary body, half in the sulcus this time. You could probably do some ultrasound or digital high frequency stuff to look at that. But that's what I would go to first, I think. Even if they were a low vault, with the Evo, I'm less concerned about a low vault, especially when you're doing the rotation. You're going to be pumping them up with viscoelastic anyway, so it's not like we're going to be dinging the lens, I don't think. That's probably what I would go to versus doing a corneal ablation or explanting it altogether. But to be fair, both of those approaches are very reasonable too, and I think that you can get to where you need to go with either of those approaches.
Priya, any thoughts on?
Yeah, when I'm picking the size for ICLs, I'm definitely thinking about, is it a toric or not? With a sphere, a spherical lens, yeah, I'm not as worried, right? And but with a toric, it really needs to be big enough, otherwise it can rotate. And I was recently talking to actually Scott Barnes about this, and he was saying that because most people are trying to undersize, since a big issue seems to be if the lens is too big with the high vault, we're seeing a lot more rotations, now. 100 micron vault doesn't worry me, but in this setting, it looks like it rotated, so it might have been too small. If I'm going to go back in the eye in this situation, I'd probably just go ahead and go up a size to the 13.2. So, in general, I think like roughly it's going to add another 500, 550, 600 to that vault. And that's still within the acceptable range. So that's probably what I would do. But
Nice.
like you said, like I think either is completely reasonable.
Totally agree. Arjan, you once clued me in on a very interesting solution for an ICL that's rotated, let's say 90 degrees. And at that point, you've doubled the astigmatism. And let's say that ICL is sitting vertical, but it's stable and seems to be rock solid at that vertical position. What's your thought on that? And I think you clued me in on this a technique that might be interesting to correct that.
Yeah, so I'm not sure which one you're referencing, Bill, but I can think of two things right off the top of my head. I think what's been mentioned so far, either just going back in and rotating the ICL or explanting it and exchanging it for a different size ICL, I think that's a really good first move. But the question then is, and this happens sometimes, what happens if it rotates again? And if it rotates again and it rotates to the same spot or about the same spot, I tend to feel that's a good indicator of what their sulcus anatomy, what their ciliary body anatomy is like. So if you're noticing that, okay, it's rotated again, or it's consistently in a certain direction, you can actually reach out to STAAR and have them manufacture an ICL with the astigmatism correction reoriented for that axis. So if maybe they just have a big sulcus or there's some odd anatomy, you can actually put in an ICL that's maybe at a different axis than where you initially intended the astigmatic correction to be, because that ICL is going to rotate towards a certain direction. But then the other method, I think, is just you have to know when you're going down this journey when to call it quits. And I think once you've been back in an eye twice to rotate an ICL, or you explant it and exchange it for a larger or smaller size, hopefully at that point the cornea is at a state where you could just do laser vision correction enhancement. And that's when I would just explant the original toric ICL, put in a spherical ICL, because it doesn't matter if a spherical ICL rotates, and then afterwards just do LASIK or SMILE to finish off the rest of that astigmatic refractive error that's remaining.
Yeah, sometimes you do have to know when to call it quits, and it can be challenging. I think, Arjan, you and I shared a patient in Cleveland. You probably still remember this very well, where a patient had ICL rotated, and we discussed. He said, "Well, we can remove it and go back in and just do LASIK to fine tune the residual prescription." The patient was very adverse to LASIK. I forget why. They just did not want to have flaps. So we said, "Okay, we could do PRK," and then we decided, we can do SMILE. And so what we ended up doing is but for SMILE, you had to have a certain amount of prescription to be able to do the SMILE. So we said perfectly, left them undercorrected with the IOL exchange as spherical, and then did SMILE to correct the residual sphere and cylinder after. So kind of a complicated case, but the patient ended up doing quite well. So it was basically initially toric ICL that rotated, and then exchange for a sphere ICL with a little bit lower power to leave room for SMILE to correct the residual sphere and cylinder. So anyway, it's complicated, but a lot of times, in these cases, you want to make sure if you're going back in, you want to have a plan that makes sense and the patient's bought into, and that everybody will have a great outcome at the end. So anyways, we're kind of getting close to our hour here, and so wanted to just make sure everybody had one last chance to say anything more about enhancements or anything more that comes to mind working with these patients. So, Blake, any final thoughts on enhancements here?
Yeah, I would say that it's important for us to realize that we live in a bubble. Those of us on this podcast and people that we talk to, and we act like, of course, you need to do enhancements. But the reality is that in most of our towns, whether it be Cleveland, Ohio, or Los Angeles, or Baton Rouge, there's just not that many people that do them flat out. There's a lot of people who do toric IOLs and multifocal IOLs, but they don't do they don't offer enhancements, at least not to to the degree that they're probably needed. So I think that for those of you who are listening to this podcast who, you know, maybe don't remember the last time they did an enhancement, but you're doing multifocal IOLs and LASIK and stuff like that, you may want to kind of think twice about how many of those people, how many of your patients are out there who are kind of mildly to moderately happy, but not quite ecstatic. And that means that they're kind of talking about their experience, in the community. You might want to think about who's seeing your post-ops. You might want to think about, would you even know if someone ended up -1, right? Or -75, and are kind of okay with their procedure, but not quite over the moon about it. That's not really what builds our specialty. It's not what builds refractive surgery. I think making people ecstatic, the difference between, I always say there's a difference between 20 happy and 20 hell yes. It's completely different. And I know that from my own LASIK experience. So I just think it's important that we kind of, take this on as comprehensive refractive surgeons, and do our best to get these people, into the end zone, doing the touchdown dance, not just hanging out on the 10-yard line. That's how I think that, word of mouth and practice building and all that stuff. That's where you get it. You don't get it from making people, better, but not quite there. You get it. You get it from, getting the grand slam. So super important to incorporate all these things that we've learned from the various scenarios. I've certainly learned a lot, and so I appreciate it.
Thanks, Blake.
Yeah.
That's awesome. Priya, any thoughts?
Yeah, I completely agree. And I'll just add to that, if for some reason you can't, for the people who are listening to this, you can't enhance them, just partner up with a LASIK surgeon that you trust. So there are a few people in town that are part of, different practices that if they have a premium lens that, patient that needs an enhancement, I'll do it for them. And, our practices work out the financial part of it. But, we speak highly of each other, and that's not a problem. I think if you're friends, we all want to have happy patients. I think that's definitely something reasonable to consider partnering up with someone. The other thing I just want to add is that it's also important to tell a patient if you know from the beginning that you can't enhance them. And I'm saying this because I do enhancements for a lot of people, and sometimes, we have, we're pretty good about that in general with the multifocal lenses. But sometimes, for example, what we call custom, which is just like great distance vision without glasses, either a monofocal or monofocal toric, you still know in the beginning, you're not going to be able to do laser vision correction on that patient. And it's important to tell them that, we can do this. We're going to do the best we can to get you glasses free, but there's still a chance that you may need glasses, and just document it in your consultation note, because then it's not a surprise afterwards if you can't do it.
Well said.
But it's been a really great experience to learn from all of you. So this has been really nice. Thank you.
Thanks, Priya. Arjan, last thoughts.
Wow. Well, what can I say that hasn't already been said? That was really eloquently put by both Blake and Priya. I would just maybe end on this note again, speaking to the listener, which is, if you're someone who's in practice and maybe you don't have access to a laser vision correction suite, maybe you don't feel comfortable doing LASIK or SMILE or PRK, as Priya mentioned, definitely partner up with someone in the community, partner up with a friend who can help you out. And I would say, when I do surgery, I try to take a lot of pride in my work. So if I'm doing surgery for a patient and the outcome the first time isn't exactly what was intended, or the patient is unhappy, or the outcome is suboptimal, I try to strive to be the best I can be and maximize my potential as a surgeon to help get them to the outcome that's desired. And that might mean learning a new procedure, or visiting another surgeon, or having conversations like this to continue to gain knowledge and understand the nuances of our field, because ultimately this is the profession that I chose, and I don't want to half-ass it. I want to make sure I'm doing the best possible job I can. So I would encourage people who aren't maybe doing IOL exchanges, or people who aren't comfortable doing LASIK or PRK enhancements, to almost in a sense go back to the books and attend conferences, attend meetings, attend webinars, talk to your friends, visit other surgeons, because being able to offer an enhancement to a patient who maybe had a suboptimal outcome, or a patient who paid quite a bit of out-of-pocket cost for a certain IOL, like Blake said, that can be the difference between an okay result, or a 20 happy result, or a 20 hell yeah result. And so I would just say, don't feel like you can't learn something new if you've been out in practice, or, I have a LASIK surgeon in town and he and she will take care of that. The patient is going to love it if you, the surgeon, continue on that journey with them and get them over that finish line. So do all you can to just make patients as happy as possible, and I think you'll find your own practice all the more fulfilling.
Well, all very well said. It's so great to have the three of you. I learned a lot tonight, and thanks for your thoughts and your time. I really appreciate it. And everybody really chimed in. I do agree that these are challenging cases, but we do need to embrace them and not ignore them. And to get those 20 hell yeah, as Blake said, I think we've got to embrace these enhancements and do the right thing and get them to where they need to be. So thank you again, and we'll see you all soon.
For more shows like the one you just listened to, check out the podcast channel on itube.net.